My name's Sue Cumming and I'm the Insight Manager for My-Dallas in Liverpool. With Richard from the back, I just want to say thank you very much because our presentations complement each other extremely well. So I've just been debating in my own mind, should I lie and say it was planned or come clean?
Definitely lie.
Because in Mi-Liverpool, what we do is we put the consumer at the heart of everything we do. So we understand our customers' attitudes, needs, wants, motivations and barriers, and we've built the whole proposition around those needs and wants and understood the customer from the heart of what we do. So in terms of this piece of work, I'm going to give you a brief sort of overview of qualitative piece of work. And we've gone out and spoken to real life sort of end users. But following this piece of work, we're going to quantify all this work. And we're going to understand in terms of quantification, in terms of attitudes and motivations. And we're going to build a segmentation model of the whole Liverpool population. So we can say from that X% of people behave in this way, they have these attitudes, they look like this, and so we need to promote to them in this way, and we can target all of our marketing strategies based on that. And that's the key to go forward, because one size doesn't fit all. We need to understand that there's different people out there who behave in different ways and have different attitudes. So what we've done, in terms of the My proposition, we've got three main elements. We've got life plans, telehealth and telecare. So we've gone out and we've educated people in terms of our population and what those are, because we can't just go out and ask what you think about life plans if they've never heard of them before. And what we've gone out is to understand people's lifestyles and related health needs and the potential role for life plans, telehealth, telecare. We've gone out and understood people's appetites, attitudes, motivations and barriers towards those three key proposition elements. We've gone out to understand how to promote and create demand. So as Richard said, how do we start being what people are interested in? We need to understand what people want and need before they even know it themselves, because often people don't know that. So we need to know that first and then build the propositions to meet those needs. We've also understood healthcare and professionals' point of view as well. So how we've gone about doing this, as well as understanding what we need to find out, we need to understand who our audience is. And so I think most of you will have seen in terms of my Liverpool proposition how it's built. It's built on the intensity of people's needs and the need for technology to help them live independently. So they're called COGs. So COG 1, these are people who we're approaching on a population-wide approach in terms of health and well-being. So we've recruited people based on this, on COG 1, in terms of people representative of our population in Liverpool. They may have long-term conditions, but it doesn't affect the day-to-day activities. For COG 2, these are people who need a little bit more help. So we've recruited people who have long-term conditions. It does affect day-to-day activities, but they currently don't have any care needs. For COG 3, we've recruited people who have long-term conditions. It does affect the day-to-day living, and they do have care needs, and these may be formal or informal care needs. And for COG 4, it's all the same as COG 3, but these are people that have been in and out of hospital all the time. So we've gone out and we've found these people that are our key target audiences, and we've made sure that we speak to them in a representative way, so we get the views of everybody that we need to. We've also spoken to carers as well, people who care for people in COGs 3 and 4, and healthcare professionals. So we bring all these findings together, and what we found is that there's three key things that we need to understand to help sell the My proposition. And attitudes and appetite are being driven by these three key things: personal resonance, individual needs and delivery. So you can't just go out and sell this. You need to understand where people are in terms of personal resonance and their individual needs. So if we look at personal resonance first, overall, the My proposition was viewed positively by our population, and everyone could think of it's either good for me now, good for somebody I know, or good for me in the future. And we need to understand where people are on this scale. But what we found was personal resonance was driven by people's attitude towards independence. Now, it was either ends of the scale, and we need to understand where people are on these ends of the scales in terms of their attitudes towards independence. On the plus side, for COGS 3 and 4, it was about being able to do things for themselves in their own home, improve the quality of life, make them feel more secure in their own homes. And for carers, it was enabling the person they care for to be more independent. So on that side, we know sort of what messages we need to give to those people. We need to build on the positives. But we had people sort of on the negative mindset of independence. And those people struggled to envisage themselves ever being independent. The fear of change, doing something new, and worried that being independent means being alone or isolated. So we need to bring all of that into the mix. We can't just go out and sell telehealth, telecare and life plans. We need to understand where people sort of sit on this spectrum. And we'll go a bit deeper into this in terms of individual needs. And what we learned from the insight is that there's a hierarchy of needs in terms of individual needs. At the bottom, we have personal security. Then we go up to well-being, which covers both physical well-being and emotional well-being. And then at the top of the pyramid, we have freedom. But we have to satisfy the bottom layer first before we even go on to well-being and then on to freedom. And I can't stress enough the key about this, because if we go straight in and sell something on being independent and being more freedom, if people's personal security and well-being needs aren't being met, they're not going to listen. They're going to disengage and go and do whatever else. So we need to understand where they are on this pyramid. So looking at these in sequence, personal security. For COGS 1 and 2, this tends to be more about about personal security in the home and local area. And mainly these people were confident about the personal security. But for COGS 3 and 4, we found that a number lacked confidence about feeling secure in their own home. And this is driven by the condition. So low mobility, sensory or cognitive impairments. And so we need to sort of think, how are we going to address these needs? Just to give you 2 case studies, and these are real life people that we spoke to in Liverpool. So we have Jean, she's in COG 4. Jean has paraplegia from the waist down. She lives at home with a husband and 2 children. When home alone, Jean is worried about people coming into her home. She currently has a buzzer entry system, but still feels she could be letting anyone in. Twice she has had fraudsters into home. One pretended to be a man from the gas company and stole things from her. So Jean is constantly worried about who is coming into her home. We have Paula. Paula's a carer for someone in COG 3. Paula cares for a mother who has severe osteoarthritis. She shares this responsibility with her brothers and sisters. None of them live at home, so they take in turns looking after the mother. Paula and her brothers and sisters are worried about the security of the mother's house. They're often getting the locks changed because they lose keys, because they've each got a set of keys. So what they do now is they juggle one set of keys between them, because they'd rather have that inconvenience than losing a set of keys and worrying who's going to get into the mother's home. So very good examples here of where security needs need to be met. So how can the My proposition help with security? We have, in terms of telecare, we've got the video entry and door sensors. And for telehealth, being able to monitor in your own home could remove the need for other people having to come into your home. So if we look at well-being, now well-being covers both physical and emotional, and the people sort of understood the link between the two. But what we found in terms of well-being, if we look at emotional first, is that people who felt unable to have a positive outlook on life often found it difficult to making changes in their lives and found it difficult to even envisage about using technology to make their life better because they weren't at that stage in their life. And the things which impacted on a negative emotional well-being included things like financial worries, having stressful lives. COGS 3 and 4 tended to talk more about feeling isolated, which affected their emotional well-being. And also for COGS 4, participants and the carers found it difficult in maintaining the condition or pain, which impacted on their emotional well-being. So in terms of how telecare, telehealth and life plans can address this, what we found in terms of telecare, if people have low emotional well-being, then they're going to find it difficult to engage with telehealth. So that's not your first entry point in terms of going in to try and sell the My proposition. Life plans, they agreed that this is the area that would help them increase their emotional well-being and get them onto the road of then looking at further needs in terms of how they can become more independent. For well-being in terms of a physical sense, COGS 1 and 2 thought about this as diet, exercise, smoking and drinking, but COGS 3 and 4 thought about this, about physically being able to do things for themselves, and so different needs again across the different COGS. And for COGS 3 and 4, this was often driven by their condition. So where people had limited mobility, all they wanted to do was being able to do small things every day for themselves, small tasks that we take for granted. Just to improve that for themselves would increase the physical well-being. So how we can then relate this back to the My proposition. Telecare can support people in doing things in their own home, but people did note there was a gap for doing wider household tasks. Telehealth can provide peace of mind, being able to monitor your physical health, and life plans, again, it's there to help sort of plan and make your life better. So we can start to see people at different stages of the journey, which different parts of the proposition are going to sort of help get them to where they need to be. So if we look at the top of the pyramid and we've got freedom. Now, again, it's different for different COGS. COGS 1 and 2, it's about feeling you're able to improve your life, and it focused more on aspirations, being aspirational. Whereas COGS 3 and 4, it was just about making the life easier. And about carers, it was about improving quality of life for people they care for. So in terms of the My proposition, telecare, making life easier in the home, peace of mind for carers. Telehealth, it can free up time and give you confidence to do other things in your life. It makes life easier by not having to go out to see a healthcare professional. And life plans about being able to improve lifestyle. So if we bring all of these together, the key is that we need to understand that people at different stages have different needs which we need to address. And again, these are real life examples. So in the freedom part of the pyramid, we had Louise. Louise was in COG 4. Now, Louise was very ill. She had a tumour on her spine, suffers with mobility problems. But Louise had a very good support network. She had close friends, family, good relationships with care professionals, and she had a good relationship with Marie Curie. So her personal security and well-being needs were being met. So she was at the stage of looking for freedom, and she already had things as mobility scooters and low-level showers, but she liked the idea of telecare as it could improve a quality of life. So because her needs below were being met, she was at the stage where it was independence that she wanted. Now, Nick, who was in COG 3, Nick has mobility impairments from a condition he had from a child. His mobility has deteriorated as he's grown older. He's moved to Liverpool to be nearer to his family, but since has found it difficult to make friends, and he just doesn't feel like going out. He lives in a small flat, finds it difficult to motivate himself to do anything. So he's quite depressed about life. He doesn't want to do anything, go out. So in terms of Nick, he finds the idea of using technology is just not even there in his life. So because he's in a negative frame of mind, so he needs help first with his emotional well-being before we even get onto the talk of technology. So life plans is for him before we even get onto talking about technology to help him improve his quality of life. So bringing all the end user insight together, the key is understanding your target audience, and people are at different stages, and it's understanding at what stage they are. And in terms of segmentation, which we're doing in Liverpool, that'll help us understand the sizes of each of those segments, who they are, where they are, and how we need to target them. But I also spoke about healthcare professional views, and to summarise their views with telehealth, telecare and life plans, they had 4 key needs. They wanted a clear and simple referral process. They wanted it to be evidence-based. They wanted to know it reduced workload and not increase it. They needed training to show the benefits and the limitations of the technologies, and they wanted leaflets to hand out to patients to make it easier to explain the proposition. Now, in terms of the insight I have, it's huge, so I've given you a very small snapshot in terms of today. There's an awful lot of information behind what I've given you, and I'm sure that we can share that with people going forward. But to conclude, put all the positives together in terms of what we need to build upon in terms of the My proposition. And I'm not going to read all of these, I'll let you just have a quick scan. And then we have the barriers. So these are the things which we need to address and work upon and turn into positives for people. So as you can see there, for Mi-Liverpool, we've got a wealth of information which we can use to actually build our proposition upon and help sell that proposition. We need to understand where people are in this pyramid in terms of the resonance, and then we can target them with the right messages that are going to resonate with them and they're going to take action from. And that's me. Okay. Now, I need to leave now, but I'm happy to take any questions before I go.
You've done on a pretty impressive 5% exercise. My question is, how far you've disseminated that information amongst the staff, the medical support staff, so they actually understand the people, the sayings that you're producing, and modify their behaviour?
We've already started to do that in terms of we have working groups that happen every week in Liverpool, and so that's already been disseminated. And there was one lady in the audience that came to one of these meetings in terms of that pyramid and security, and afterwards she said, "Thank you so much." She said, "My mother's recently become ill over the last 6 months," and she said she's banging on about security time and time again, and to be honest, she's annoying us now because that's all she wants to know about and that's all she's talking about. But she said, "I understand now where she's coming from, and I'll view it in a different way and approach her in a different way." And these are people on the front line. These are people that are actually going out and speaking to people. So it's sort of being disseminated down the line in terms of the actual professionals who are going out to use it.
I work with an NHS organisation. Of course, we have to think about universal coverage, and engagement tends to differ in terms of the private sector, which can draw walls around the target audiences.
Yeah.
So I guess the question is, why 4 groups? is why 4 cogs? What's driven that, and how do we drive an integrated segmentation of our population so that we can work across sectors in an integrated way?
Right, well, the 4 cogs were something that's been designed first within Liverpool. In terms of the segmentation that I'm designing from a population viewpoint will not be 4 segments. We don't know how many segments we're going to come back with yet until we've actually crunched all the data. So it could be 5, it could be probably no more than 6. But in terms of those 4 cogs, we've just used that to help us identify a representative sample of people that we need to speak to. That's not necessarily our segmentation model for marketing purposes and promotion purposes going forward. Has that answered the question?
Yeah, I guess the question is then, that's Liverpool have segmented into 5 or 6, we've done that work, which is really valuable. It's not having different classifications in different areas with different sectors, which we can't develop. That's a challenge, really.
I know, because we've gone out and we've spoken to our people in Liverpool, and that segmentation is going to be bespoke for Liverpool. It's going to be on our population. So unfortunately, it's not to say then everyone else's population will be the same. I'm sure it can be built on with everybody else and the same attitudes measured, but you may find that the segments then vary in size for different areas. So I can't give you the answer for your area, that's just going to be for Liverpool.
I think just to follow up as well, we started with the 4 cogs in Liverpool because we looked at use cases for telehealth, telecare, people using a life plan of one form or another, and general engagement with the community, with those people who weren't in the system at all. So that's kind of where the initial segmentation came from. So it was derived from the use cases from our initial TSB proposition.
But I wouldn't really call the COG segmentation, it's just defining our target audience to start this journey and understand them. Okay. Okay, thank you very much. Thank you.